Let's discuss about disorders of gait. Overview. We'll discuss about physiology, anatomy, biochemical aspects of gait, and history, examination of posture and walking, motor and sensory examination, and classification of the gait patterns. The gait is basically a series of rhythmical and alternating movements of trunk and limbs which result in the forward progression of the center of the gravity and body. Many diseases are identified by the disturbances of the gait and posture they produce. So, we need the posture along with the reflexes, and then we'll get the locomotion. The posture helps in the stability and is based on the musculoskeletal linkage between the trunk and legs, and the neurological control detecting and correcting the body sway based on the reflex arc. And the reflexes are automatic writing reflex, feed forward reflexes, and feed backward reflexes. The locomotion is once the trunk is upright and stable, then the locomotion can begin. The postural reflexes restore the posture when the posture is disturbed. It can be either peripheral like stretch reflexes or central like vestibulocerebellar reflexes. So, with the visual feedback, with the vestibular feedback, and proprioceptors and somatosensory feedback, the impulses are sent to the muscles, and these are the writing reflexes. Supporting reactions will control the anti-gravity muscle tone. Anticipatory feed-forward postural reflexes occur before the movement, and reactive feed-backward postural adjustments counteract the body's perturbations during the movement. And there are automatic writing reflexes. These writing reflexes are labyrinthine writing reflexes, which sense the gravity as the stimulus, and response is the writing of the head, and the receptor is the otolith organs. The neck writing reflexes stimuli is the stretch of the neck muscles, and they respond in the form of writing the thorax, shoulder, and pelvis, and the receptors are muscle spindle as the stimuli is the muscle. And the body writing reflexes are body on head and body on body. Body on head has stimulus from the pressure on side of the body, and its response is by the writing of the head, and the receptors are exteroreceptors. And similarly, body on body also does this, and the response is like writing of the body when the head is held sideways. All the reflexes have the center in the midbrain. Next, coming to the locomotion. The initiation of the gait is heralded by a series of shifts in the center of pressure beneath the feet during the course of an anticipatory postural adjustment. This sequence is then followed by stereotyped stance, swing, and step phases of the gait cycle. So now let us look at this gait cycle. The stance is the phase of the gait cycle where the foot is touching the floor. Any part of the foot can touch the floor, whereas the swing is the foot is in the air, not striking the floor. So the stance phase is having some phases. Firstly, the heel strike. So we have normally the heel strike gait, not the toe strike gait. We'll touch the floor first with the heel, then the foot flat, which means the contact of the foot to the floor, and then we'll remove the feet, heel off, and will there will be propulsion to the toe off. This thing is of stance phase, and now the foot is in the air, and we'll keep our foot away, like we'll go forward in the air. That is the swing phase. And the next the stance phase starts with the heel strike. So see, out of this stance phase also, there is a double support phase, single support phase, and again the double support phase. Suppose the right leg is in the stance phase, that means it is in touch with the floor. Initially, the left foot is also in the support, but then the left foot will take the swing phase and again land up. So this is the double support where we have support of both the right and left leg, and lastly also right and left leg of the stance phase. And next the swing phase where the right leg takes its swing phase and the left leg will be in the stance phase. So what are the anatomical aspects of the gait? The neuroanatomical structures responsible for the equilibrium and locomotion are situated in the brainstem, cerebellar locomotor region, and also in the spinal cord. So this is a complex but yet a mind map of what happens actually during the gait. So all the visual signals will reach the cerebral cortex, all the proprioceptive impulses will go to the spinal locomotor network and also to the thalamus. From the thalamus again the signal will reach the cerebral cortex. So from the cerebral cortex actually and also other stimulus like from the cerebellum via the vestibular signals. We have three main sensory inputs for the stabilization or equilibrium. One is proprioceptor signals, another is visual clue, and other is vestibular. These three are the sensory stimulus. So if any two of these is lost, we'll have imbalance. If any one is lost, other two can manage. For example, if there is any cerebellar pathology, or suppose if there is any proprioceptor signal loss, that means sensory stimulus is less. So our brain utilizes more of visual clues. That means the patient can be stable without any imbalance as long as he uses his eyes to check where he is, what is the position of his limb, and everything in the surroundings. When eye is closed, that means we are eliminating two stimuli. Already he has lost his proprioceptive signal, and also we are eliminating the visual clue. Only with vestibular signal he cannot have the proper balance and he falls. So the main three are proprioceptive, vestibular, and visual. At least two are needed properly. And another thing which modulates and coordinates all these things is the cerebellum. So proprioceptive signals reach the cerebral cortex, vestibular signal will reach via cerebellum and also the vestibular nuclei, and visual signals will reach the cerebral cortex. And finally, from the cerebral cortex, everything will reach us to the basal ganglia and also the limbic system to the pontomedullary reticular formation where the neurons for rhythm activation and neurons for support and balance are present, and it gives impulses from the vestibular nuclei and also spinal locomotor network. From there, motor output, motor neurons will be there, and the locomotion starts. Now, next, coming to the cortex, we have prefrontal cortex from where corticobulbar and corticostriatal tracts modulates the midbrain and cerebellar locomotor regions. And the parietal cortex is mainly helpful for integration of all the sensory outputs that reach the cortex. Next, the cerebellum modulates the rate, rhythm, amplitude, and force of the stepping, and this contributes to the medial brainstem efferent system controlling the truncal posture and equilibrium through the projections from the flocculonodular and anterior lobes. That means the midline of the cerebellum, mid part of the cerebellum, we can say it helps to maintain the posture of the axial skeleton of the body, whereas the lateral hemispheres help for the posture and movements of the lateral, that means limbs of the body. Trunk posture is mainly done by the midline, anterior lobes, and flocculonodular lobes of the cerebellum. So before approaching to any patient, how can we approach a patient with a gait disturbance? That is, just take a detailed history of walking and the difficulty of walking, which provide the first clues for the diagnosis. And also ask the circumstances in which their walking is difficult and the leg movements most affected, and are there any associated symptoms, especially the falls, which may be the presenting feature itself. So take the weakness, pattern of weakness. Is there any slowness or stiffness, imbalance, tinnitus, vertigo, dizziness, like suggest of vestibulopathy? Are there any sensory symptoms for proprioceptor? etiology, is there any urinary incontinence for normal pressure hydrocephalus where there is an also ataxia, dementia, urinary incontinence? Are there any cognitive changes so as to assess even for the prefrontal cortex? Slowness is seen in elderly persons, Parkinsonism, or it could be also any normal response. We'll ask a history regarding all of these things and we'll assess each of the symptoms. Imbalance, if there is any symptom like poor balance and unsteadiness, it is a cardinal feature of the cerebellar ataxia. Sensory ataxia due to proprioceptive sensory loss or vestibulopathy or vascular lesions of the thalamus or basal ganglia and frontal lobe disorders. All these patients mainly present with imbalance. How can we differentiate cerebellar from the sensory? In cerebellum, unsteadiness, staggering, and inability to walk in straight line, that is, walking in a straight line will be difficult and there will be near fall. Whereas in sensory, only there will be unsteadiness in the dark because, as we already discussed, the visual compensation is lost. Cerebellar etiology, turning and suddenly changing the direction results in veering to one side, the uh, ipsilateral side swaying will be there. If there is pathology of the left cerebellar region, the patient will sway to the left. Whereas in sensory, he will complaining of being uncertain of the exact position of the feet also. And cerebellar pathology is exacerbated by an uneven surface and also sometimes sensory also. But sensory is more, the patient will tell like he's feeling like he's walking on a spongy surface or a cotton wool. Coming to vestibulopathy, there will be difficulty in focusing vision also on a fixed target, and loss of stabilization of ocular fixation by the vestibular system will be there. If it is acute, it is associated with vertigo and severe imbalance, but chronic lesions may be well compensated, only revealed when visual or proprioceptive input is compromised. So, chronic vestibular dysfunction often causes wearing and problems in the environment with many objects, such as walking in shopping malls or crowded streets, like that. In such a situation, the chronic vestibular dysfunction gets up. So, now examine the patient after taking the history, examine the posture and walking. How is he arising to stand from a seated position? How is he standing? How is he walking? How is he turning? And do other maneuvers. So, arising from sitting to standing, what does it imply? Firstly, from sitting to standing, he should have good pelvic girdle strength. That means he should actually arise from a chair without using his arms. So, we'll assess the pelvic girdle strength. If he's using his arms, holding the hands of chair for getting up from chair, that indicates there is some muscle pathology or proximal weakness that is unable to arise when the feet are appropriately placed on the body while sitting and turning if the trunk is leaning forward. It indicates proximal muscle weakness. If there is an incontinence or balance or imbalance, after while he is just standing, he takes a wide stance base when he is standing from a seated position. If there is any frontal lobe disease and a higher level gait disorder, there are inappropriate strategies in which feet are not positioned directly under the body or trunk body, or the trunk leans backwards rather than forwards when trying to stand. So now we'll see what happens in standing and walking. A stance phase where we have already seen the foot touch is in touch with the floor. Wider base is the first compensatory effort in most of the gait disorders, as seen in cerebellar or sensory and frontal lobe disorders and diffuse cerebrovascular disease. And what is Rombuck's test or Broad's Rombuck sign? It explores for the imbalance due to proprioceptive sensory loss and compares balance as the patient stands with eyes open and eyes closed. So, inability to maintain balance with eyes open and feet together is not a positive rhombus. That means even with his eyes open, he is unable to maintain balance. That means it might not be due to the proprioceptive loss. It might be due to other things like cerebellar or vestibular pathology. only if the eyes is closed. If the eyes is closed, is unable to maintain the balance, but maintaining the balance with eyes open, that indicates a rhombus positive. In order to test this function, the patient must have a stable stance that with eyes open and then demonstrate a decrease in balance with eyes closed when the visual input is eliminated, and the patient must rely on the proprioception to maintain the balance. But the Rambam did not state that the feet should be placed together. That was a later addition. Nor did he comment on where the arms to be positioned. The turning head side to side eliminates vestibular clues and increases the reliance on the proprioceptions. This is Roper's redefined Romberg's test. It is so. What we do is we have the patient hold the arms outstretched in front, and sometimes we'll ask him to rotate his head or extend his neck. But this just in order to check simultaneously for everything. The outstretched hand to test for the pronator drift, and turning head is to check for vestibular pathology simultaneously. But this is not actually what the Romberg actually described. So look at this patient. She's standing with eyes open perfectly. There is no imbalance, and now she closed her eyes. So if she falls now, that indicates a positive rhombus. The patient should immediately fall after closing the eyes. It is a slight swaying towards any side. That doesn't indicate rhombus, but if the patient is having significant proprioceptive sensory loss, he immediately falls after closing his eyes. So now let us see the rhombus, modified rhombus test, where we ask the patient to keep his or her arms outstretched, keep his or her feet together, and sometimes we'll also ask them to extend their neck to assess for any vestibular pathology simultaneously, outstretch arms to test for the pronator drift. But this is not what actually described by the rhombus. That's it. So now we'll check for the vestibulospinal reflexes to assess for any vestibular pathology. One thing is Unterberger-Fukuda stepping test, and other thing is star walking test. What is Unterberger-Fukuda stepping test? The patient is asked to walk in a place and will assess after 50 to 100 steps. Just at the same place, he should keep stepping. Actually is closed with his eyes. We are eliminated the visual clue. So this test identifies the weaker labyrinths by the direction of the rotation of the patient while walking in a place with his eyes closed. Maximum rotation in a normal individual is 30 degrees to either side with 50 steps. But a deviation more than 30 degrees suggests an asymmetric labyrinthine dysfunction, and the weaker side identified by the direction where the patient rotates. So here, look, he's rotating towards his right side. So right labyrinth might be weak. This method should not be used alone as a screening measure, but used with other tests for the vestibular dysfunction. What is star walk test? In this test, the patient closes his eyes, takes several steps forward and several steps backward over and over. A normal individual will begin and end oriented approximately along the same line, but a patient with vestibular pathology will drift towards the involved side of the walking forward and continue to drift during the backward also. So this entire thing results in a path which when we trace it results like a multi-pointed star pattern, that is star walk test. Coming to the postural responses, we'll assess the postural responses one with a pull test. We'll pull the patient backward, and the pull should be sufficient to require the patient to step to regain their balance. A few short shuffling steps backward or impending fall backward suggests that there is an impairment in the writing reflexes. C. This patient is walking normally and suddenly the examiner pulls him backward. If the patient doesn't have proper responses, he will fall with the pull. See, he's taking many steps backward. That means he's unable to stop also. This is retropulsion. Mostly we'll see that in the patients of Parkinsonism. Now, we'll assess the walking. How is initiating, stepping, turning, and what are the challenges faced. So the thing which you're seeing on the left upper corner is tandem walking. That means walking in a straight line. That will be more difficult in a patient with cerebellar pathology. That means he is walking heel toe walk, that we call tandem walking. Next, the right lower quadrant, you are seeing the patient is walking either on the heel or on the toe to produce an obvious minor underlying cerebellar function or any gait difficulties. So we'll summarize the type of gait ataxia mainly from the cerebellar, sensory and the frontal lobe disorders. Cerebellar pathology, the trunk will lean forward, sensory stooping posture, and frontal lobe disorders will be usually upright. The stance is wide based in all the three gaits, and the postural reflexes, we know they are impaired in the frontal lobe, whereas intact in the sensory, it might be variable in the cerebellar. Initiation of the gait difficulty, that what we call as start hesitation, is characteristic for the frontal lobe, whereas the patient with cerebellar and sensory ataxia can initiate the gait normally. The steps will be staggering or lurching like alcohol intake patient in cerebellar, whereas sensory it will be high stepping and front. So high stepping is mainly for reinforcement, more reinforcement for the sensations, as the sensations are diminished in these patients. They keep, like, it is called a stamping gait. Frontal lobe will be short shuffling, and the gait will be very slow in this frontal lobe disorder patients, whereas normal or slow in cerebellar or sensory. Heel to toe testing is very difficult in patients with cerebellar and frontal lobe disorders, where sensory patients can do. While turning, cerebellar patients veers away. Sensory turning is not much affected. Frontal lobe, there will be freezing or shuffling while they're turning. Freezing means as if their um feet are glued to the thing. Like it is magnetic gait of frontal lobe also, but freezing means patient is unable to do the forward movement of the body as if he has been frozen in the particular place. This is especially we can get this freezing where they're walking through an obstacles or narrow path or turning corners. And Romberg test, obviously it is positive in the sensory, whereas in the rest it is variable. Heel to shin test is usually normal in frontal lobe, abnormal in cerebellar, and it is variable in sensory. That means if with the eyes open, the patient can do heel to shin test, but with eyes closed, it might be somewhat difficult in sensory patients. Coming to the falls, it is very common in frontal lobe disorders, early falls. There could be falls in sensory, but cerebellar falls are uncommon. So classification of the gait patterns, after assessing everything, we'll classify either it is a higher level or middle level or lower level. Lower level means the force. That means, and force in sensations. Motor neuron, muscle, sensory nerve, proprioception, vestibular nerve, and the vision. All the three stimulus which we have discussed, and also the muscle and the motor neuron. The middle level means the connection between the prefrontal cortex and this lower level thing. That means corticospinal tract, basal ganglia, cerebellum, and the motor cortex. Higher level means it is a prefrontal cortex which interprets, integrates sensory inputs, and organizes the motor output. So lower level means, as we have said, muscle, motor neuron, and sensations. See, this is myopathic gait or waddling gait. It is due to the weakness of proximal leg and hip girdle muscles, which interferes with the stabilizing the weight-bearing side of the pelvis, and this pelvis drops. This produces an exaggerated rotation of the pelvis with each step of the waddling gait. This is neurogenic gait or steppage gait. The muscle weakness of the peripheral nerve origin. Typically affects the distal leg muscles. Patient lifts the leg and foot high above the ground with each step because of weakness of the ankle dorsiflexion and foot drop. Unilateral foot drop, a common peroneal or sciatic nerve palsy or alpha radiculopathy is the usual cause. This is slapping gait or sensory ataxia of sensory ataxia. Patients with sensory ataxia classically teres dorsalis lift the feet high up and then slap them down smartly to improve the proprioceptive feedback. Since both of these gaits are high stepping gait, both have been referred to as steppage gait, but causes and mechanism are somewhat different. So, in a vestibular imbalance vertigo, it results in leaning and unsteady rearing to the side of the lesion. Patients with acute vestibulopathy prefer to lie still to minimize the symptoms of acute vestibular imbalance. In chronic vestibular failure, gait may be normal, though unsteadiness can be unmasked during eye closure and rotation of the head from side to side while walking. Coming to the middle level gait disorder, like spasticity will be there in corticospinal tract lesion, ataxia will be there from disturbances of the cerebellum and its connections, hypokinetic in basal ganglia, lesions of Parkinsonism, hyperkinetic gaits are associated with chorea, dystonia, and other movement disorders. We will see the spastic gait of the hemiplegia, or we call it a circumduction gait. Spasticity of the arm and leg on one side produces the characteristic clinical picture of a spastic hemiparesis. Arm is adducted, internally rotated at the shoulder, flexed at the elbow, pronated at the forearm, and flexion of the wrist and finger. The leg is slightly flexed at the hip, extended at the knee, with plantar flexion and inversion of the foot. So the swing phase is slight lateral flexion of the trunk towards the unaffected side and hyperextension of the hip on that side to allow slow circumduction of the extended parietic leg as it swings forward, dragging the foot or catching the toe on the ground. Scissoring gait, spasticity of the both legs gives rise to spastic paraparesis. So both legs are stiff and both legs circumduct. Coming to the cerebellar ataxias, we know the vermis controls the midline, vermis and midline controls the truncal posture, whereas the lateral lobes look for the limbs. So diseases of the midline cerebellar structures like the vermis and anterior lobe produce loss of truncal balance, increased body sway, disequilibrium and gait ataxia with wide base stance. The legs are stiffly extended and the hips are slightly flexed to crouch forward and minimize the truncal sway. So, if suppose we see the patient in sitting posture, we cannot recognize these things. We should ask the patient to stand to notice this because leg coordination during the heel to shin test may be relatively normal when the patient is examined in the supine position. What happens in supine position is there will be effect of the gravity also. So they can do that too. But in the standing, not the gravity exactly, but they can do that. Do the coordination will be better. But the leg coordination during heel to shin may be relatively normal in the supine position, whereas we can notice that in the standing position. Midline cerebellar pathologies include structural lesions, paraneoplastic syndromes, and malnutrition like alcohol. A pure truncal ataxia may be the sole feature of a midline that is Vermis syndrome, and the truncal gait ataxia of the midline cerebellar pathology has a lurching and staggering quality. It is more pronounced when walking on a narrow pace or heel-to-toe walking. Steps are irregular and variable in timing, that is dysynergia, length and direction, that is dysmetria. Steps are taken slowly and carefully to reduce the tendency to lurch and stagger. These defects are accentuated when attempting to walk heel to toe in a straight line. So see this thing. Tandem walking is very difficult in this patient. He is having a cerebellar ataxia. He is unable to do the tandem walking. And look for the titubations, that is nodding of the head. Titubations are not much localizing for cerebellar lesions, that means of which lobe is involved, it is not much localizing value. See, there is nystagmus, spontaneous and gaze evoked nystagmus are present, and there is also dyssynergia, small, jerky, clumsy movements. And there are intention tremors, which are tremors on action only. There is dysmetria, impaired finger to nose test. There is fast pointing. There is dystinocokinesia, impaired rapid alternating movements. All these signs we can see in a patient with cerebellar pathology and rebound phenomenon, unable to stop after active resistance. Okay. Now, if there is lesion in the anterior lobe of cerebellum, there is sway of the trunk and also there is titubation that is superimposed on the gait ataxia. So the truncal gait ataxia along with truncal tremor is characteristic of some late onset anterior lobe cerebellar lesions, exacerbated by the rapid postural adjustments needed to change the direction, turn a corner, or avoid obstacles, and when stopping or starting to walk. Minor support such as holding arm during walking, visual compensation reduces the sway in the cerebellar ataxia, and eye closure may heighten the anxiety about falling and increase body sway, but not to the extent that is observed in the sensory ataxia. There are some episodic ataxias also, like uh, during alcohol intoxication or some drug usage might be there. Spasticity along with ataxia produces a spastic ataxia. It is called a bouncing gait, seen in Arnold Chiari malformation, hydrocephalus, and multiple sclerosis. So in Parkinsonism, hypokinetic gait is seen. In early PD, it is asymmetric in early phases. That is very, very important. The classic Parkinson disease is asymmetry. At the onset, the asymmetric reduction of arm swing and slight slowing in gait, particularly when turning, is characteristic. In advanced PD, there is stoop posture with flexion of the shoulders, neck, trunk, and knees. Unblinking and mask-like facial expression, poverty of the movement will also be there. And fascination. The patient advances with series of rapid, small steps with narrow base, though trying to catch the center of the cavity will be there, and there will be start hesitancy. That is main feature. See this patient. There is starting hesitancy. Is having some difficulty to start the movement, but once he starts, slowly the movement will aggravate. This is fascination. Then start hesitation, and fascination with drooped posture, and there will difficulty in turning also. This is freezing. You suddenly stop there to turn, and slowly this is en bloc turning, like step to step to step turning, and again start hesitancy to start the movement, and then he starts slowly. Suddenly he picks up the space. Yes, yes. Now coming to the choric gait. These random movements of the chorea are accentuated and often most noticeable during the walk. Superimposition of the chorea on the trunk and leg movements of walking gives dancing quality. Dystonic gait is focal dystonia can be there which results in inversion or plantar flexion or distortion of the pelvis and also all the other places in the trunk. The patient sometimes may have to walk with the knees flexed also. Open-heel's gait is a prominent buttocks with flexion of one or both of the legs at the hip. Remember, leg muscle tone in some upper dystonia may be normal when the patient is examined in the supine, but it is increased during walking or in action. This is action dystonia. See, the patient is having dystonic movements of left upper limb, also both of the legs. Coming to the last, higher level gait disorder is a term used for the locomotor and balance difficulties that cannot be explained by the middle or lower levels. There are multitude of the terms used to describe this like gait apraxia, frontal ataxia, petit spas due to vascular damage to the frontal lobe, and lower half Parkinsonism, and many more. Diagnosis do not mean that there cannot be signs of lower level dysfunction, but the lower level dysfunction alone is insufficient to explain the gait disorder. Some disorders may begin as middle level and evolve into the higher level gait disorder. Example, Parkinsonism. First, simple slowing of the gait. It will be responsive to the levodopa, so classified as a middle level. But with time, that means as of the basal ganglia, so middle level. So, but with time, balance difficulties and freezing will develop that are poorly responsive to the levodopa. Then it is considered as higher level. So, middle level evolving into the higher level. Loss of integrity at the cortical basal ganglia levels of essential elements of stance and locomotion that are acquired in infancy and lost in the old age. Disequilibrium will be there, falls, wide base stance, short shuffling steps, hesitancy, magnetic gait, retropulsion, freezing, all these things can be seen. How can you differentiate this thing from the other levels? Here, there will be performance varied with time depending upon the environment and mood. Fatigue could increase abnormal gait patterns. Start and turn hesitancy or freezing of the gait is common. Rescue reactions are absent. Postural synergies are inappropriate. Examples are Parkinsonian syndromes, multi-infarct states, and normal pressure hydroscopies. Apraxia is the inability to carry out purposeful movements that cannot be attributed to the weakness or sensory deficits and incoordination. It is often considered to be the basis for the higher level gait disorder, particularly for the freezing of gait. That means the motor system is normal, the sensory system is normal, and there is no much incoordination, but the patient is unable to carry the gait normally. This is apraxia. Limb apraxia is associated with dominant parietal lesion. Conversely, gait disorders in general, freezing of gait in particular, are associated with bilateral medial frontal lesions. Thus, the balance and gait deficit in higher level gait disorder fit the broad definition of apraxia. But they are clearly different from the general concept of apraxia that was developed from the problems that occur in the limbs. See the freezing of the gait. The patient is there is start hesitation and slowly he started to walk. He's walking and there is increase in the pace, fascination. But suddenly there is stoppage of the gait. He should turn into the room. Okay, started the movement again and block turning. This is freezing. He stopped there. See the magnetic gait. He's walking, but suddenly there is stoppage of the gait, as if the foot has been glued to the floor. He is unable to start again. This is freezing of the gait. It is seen in normal pressure hydrocephalus also. There is one term called Pusher syndrome where the lesion is in the parietal and the thalamic areas, which is usually seen in stroke. There will be the sense of postural vertical movements can be disturbed or other distortion of the environment and body mass. How can you just differentiate between the Parkinson's disease, classic disease, and symptomatic Parkinsonism, in which both patients will be having the stoop posture, but Parkinson's disease will have a narrow stance, whereas symptomatic Parkinsonism has a wide base and destination is rare in them. Heel to toe is poor, postural reflexes are absent at early stages, and falls are present early in the disease onset. So these patients will adapt certain things, that is cautious gait. In Due to the fear, they will have certain behavioral patterns like short steps, slow and block turns will be carried by them to avoid falls. Reckless gait. Patients with impaired postural responses and poor truncal control who do not recognize their instability and take risks that result in falls and injury. This impulsivity and a failure to adapt the precarious balance are part of cognitive decline. Example, frontal dementias like progressive supranuclear palsy and frontotemporal dementias. In aged people, there is loss of speed and balance, stooping of the posture, shortening stride, slightly wide base stance, and turning en bloc. In hysterical or psychogenic gait, they typically do not lift the foot while walking, but tend to drag the leg. They take vivid postures, lurch, dystonic, exaggerated movements of the arms, and Hoover sign will be present. And with this we call as ataxia, abasia. That means they are unable to walk, stand or walk, but normal usage of the leg in the bed with normal examination findings. Antalgic gait is due to any pathology in the joint causing the pain. So the stance on that leg will get affected. So there is the slowness of the swinging phase and short duration of the stance phase. So we'll do certain rehabilitative measure for these patients. Like in spasticity, antispastic agents or vestibulopathy will give them balance training and vision training and discontinue the vestibular sedatives. Leg muscle strengthening programs and ventricular shunting in hydrocephalus and gait training in psychogenic gait. Thank you for your patience listening.